Thank you, Esther, and thank you to you all. It's a pleasure to welcome you here to our first dialogue of the new year. My name is Ken Goodman. I direct our Institute for Bioethics and Health Policy, and I'm delighted to welcome you to our series Dialogues in Research Ethics. Now in its, forgive me, sentiment, its 32nd year. I believe this is our 211th dialogue, where over the past, we're in our fourth decade, which makes it sound really rather long in the tooth. But what we've done here is try a number of different ways to include people whose work addresses interesting challenges in ethics and the biosciences, actually not even just the biosciences. And so it's a pleasure to be able to welcome you. You will forgive me another bit of sentiment. Since we last met, a friend and mentor of ours, this program, this series actually died. I just wanted to send a shout out. That our authority extends to wherever the shout outs go to somebody who's died. But Richard Bookman, who was Vice Provost for Research, neuroscientist, a pharmacologist, and a much beloved colleague died a few months ago. Among the sources of inspiration we seek in trying to create these intellectual communities are people like Richard, and I wanted to acknowledge that. Today we have a very special visitor from Chicago. And I'm going to ask Dr. Mike Huber, who works with us as the Institute for Bioethics, co-chair of the Health Ethics Service, to introduce his colleague and friend from the University of Chicago. Dr. Huber.
Thank you everyone for joining. So yes, Dr. Parker, my colleague and friend, is an assistant professor of medicine and public health sciences, and assistant director of the MacLean Center for Clinical Ethics at the University of Chicago. He's a pulmonary and critical care physician, medical ethicist, and health services researcher who studies the allocation of scarce medical resources. In addition to co-directing the University of Chicago's Ethics Consult Service, he runs an NIH and Greenwall Foundation-funded quantitative bioethics lab focused on absolute scarcity problems in which demand exceeds supply and healthcare systems triage patients for treatment using algorithms. His work has appeared in the Hastings Center Report, Health Affairs, JAMA Health Forum, USA Today, Washington Post, New York Times, and many other prestigious places. He has been recognized with National Young Investigator Awards from the American Society for Clinical Investigation and the American Thoracic Society. We're very happy to have Dr. Parker here to present.
All right, thank you so much for the introduction. Dr. Huber.
Share the Zoom.
Yeah, I'll share.
For you.
Perfect. If people on Zoom, if you have problems seeing or hearing, just let me know, okay? Yeah, thank you so much for the invitation to speak at this storied event. What a history, and come down to a much warmer climate than I'm experiencing currently. My disclosures are just the grant support that Dr. Huber mentioned from the NIH and the Greenwall Foundation to think about this exact problem. What I hope to do today is, trigger warning, there's going to be equations and math in this is talk about the statistical task of classifying some, particularly classifying patients in a medical context into likely to have an event or not. And I'm going to make the argument that there are several very important normative choices embedded in that process that often designers of algorithms, people with technical knowledge about statistics are making without necessarily thinking about the ethics itself. Then once we have the terminology and the necessary notation developed in the first part of the talk, we're going to talk about different non-discrimination criteria for classifiers, or this is what we talk about if an algorithm is fair or unbiased. It turns out that there are three mutually exclusive ways that can be true, and we're going to kind of walk through all of those. Please interrupt me at any time. It's great to have a smaller group and with questions, and this is definitely something a talk that I'm developing and thinking a lot about, so I really will appreciate your feedback. A lot of the source material, maybe we can hide the floating meeting controls, comes from this book called Fairness in Machine Learning. If you just
Go back.
if you hide the meeting controls, I can do it. This book is really great. It's written by a bunch of MIT. There we go. I guess I could have hit that. I was really fancy. Keyboard, but so MIT machine learning experts and a lawyer, thinking about technical definitions of fairness and algorithms. That's where a lot of the content I'm going to be talking about is going to come from ultimately. I'm also inspired to do this because of getting to know John Harrington through ASBH, the University of Rochester's philosopher of science, also really interested in quantitative bioethics, or he's, quantitative bioethics, stuff to say. There we go. All right, so first part of the talk is going to be a little bit of statistics review. So get ready. We're going to, and then talk, once we're equipped with that basic reminder of statistics 101 in healthcare, I hopefully will show you where the ethics comes in. So what's a classifier? A classifier is a statistical model that predicts group membership. This is the classic MNIST and this handwritten digits task. This is the first one that was kind of solved by deep learning, where the features, which is the X in this picture in the machine learning world, is what the person's actually drawn on the page. So it's 28 by 28 gray cell pixels. So it's got 2 position attributes and a color attribute. That's the information that the algorithm has to make the prediction. And the prediction is the Y, which is the number that the person's trying to write. And so we all look at this screen and our minds are classifying and assigning labels to each of these pictures. And what a convolutional neural network, or this is a form of deep learning, does is recreate a version of what's happening in our mind, which it allows us to see things like a 4 or a 9, even if it's drawn in a slightly different place in this box, can be perceived by the neural network to be a 9. In more simple regression-based classifiers, each position attribute is sort of fixed and considered independently in a linear combination. You have to be able to do something somewhat complicated with your mind to realize that these are all ones, even though one is tilted, right? And that was the big innovation, convolutional neural networks. If you ever take a class, machine learning or deep learning, this is like one of the first assignments, homework assignments, is to recreate a convolutional neural network that can solve this problem. And so the image goes into this black box and it spits out a guess. So for every picture, there's a Y hat, which is the algorithm's guess of what number that image is supposed to represent. And so here's another picture describing that, right? Here, correctly mapping each one of those handwritten digits to the label that it was supposed to represent. And this is a classifier in classic machine learning literature, right? Or a AI task that's very common. But in healthcare, we have different tasks, right? We want to predict things like, is this patient likely to die in the next 90 days? So I can initiate a goals of care conversation or palliative care consult. And that already we're talking about, well, why do you care about that in the first place is a normative question. But sort of setting aside that there are these clinical prediction tasks that we all recognize for being very important, we're going to have to build a classifier now, not to label a picture as a digit, but actually predict a human being's risk of an important clinical outcome. And so with Siri, this model I was showing you an example of is a model developed by the University of Pittsburgh to do just that, predict mortality within 9 days of admission. So it seeks to classify patients, in this case, an 85-year-old man with advanced lung cancer, with pneumonia, using a black box model into whether they'll be alive or dead. So it's actually in some ways easier, right? There's only 2 classes, alive or dead. But in terms of, as we'll find out, it's a lot harder to get nearly as accurate with human beings because we're not just pictures, where all the information that we need to accurately guess Y is encoded in the X. So just kind of walk through the translation into the medical context. Y is this healthcare outcome we want to predict. 0 is alive, 1 is dead. X is this group of patient characteristics, the features of machine learning literature parlance. In this model, they picked 390 variables from electronic healthcare record, including some that are highlighted in green, which are sensitive attributes, which we'll talk about in the second half of the talk. Those all get fed into the model to make this prediction of alive or dead. And this Y with a little hat on the top of it is the AI guess, the algorithmic guess about whether or not the patient will live or die. So this is the classic confusion matrix, right? The 2 by 2, one that we've all learned we're calculating sensitivity and specificity for the first time. The rows here are the machine learning prediction. Y hat is machine learning algorithm thinks they're going to die. Y hat equals 1 means predicted to die. Y hat equals 0 means predicted not to die. True positives are when the people predicted to die actually die. False positives are when you predict someone to die and they don't die, right? And the same thing goes for false negatives and true negatives. A perfect classifier is always right. So if you predict the patient's going to die in 90 days, then 100% of them do. There's nobody in the red false positive box, and there's nobody in the blue false negative box. I know it's all review for now, but it's I think important to establish before we get into where the ethics lies. And this is the receiver operator curve or receiver operator characteristic curve of a perfect classifier. The x-axis is that false positive rate I mentioned earlier, and the y-axis is the true positive rate. And a perfect classifier has some area under the receiver operating characteristic curve of 1, because everyone it predicts is going to die dies. In this context, everyone it predicts that's not going to die doesn't die. If you think about how creepy this would be if we had this in clinical practice, right? It was actually 100% accurate in a sense. And so you get all this area of this box, and it's 1 and 1. So 1's 1. That's where the AURC comes from. And what that T is is the idea of the threshold of predicted probability, which we'll come back to in a second. That's where you make the decision. All right, this person's likely to die or this person's not. Making sense? Please feel free to interrupt me with questions, or it's gonna be harder probably with this reverse. And I think I said a lot of this here. The x-axis is the false positive rate. We want that to be 0. The true positive rate is sensitivity. We want that to be 1. And so perfect classifier is right there, right? It's not misclassifying anyone. That's not saying anyone who's going to die, or say it's not saying that someone's going to die who doesn't, and it's correctly identifying all the people who die. It's perfect. These don't really exist, even in the MNIST problem, but it can get kind of arbitrarily close with deep learning. This is why they've scaled the problems up when you're trying to decide whether or not you're a robot or not, right? Like they're getting harder, and there's like pieces of buses and stuff, because the easy problems, like click on all the ones, for example, have been solved. And so then as AI continues to take off and these neural network architectures get more and more complicated, they can solve increasingly more difficult image recognition tasks. All right, but humans are not pictures. Like all the information to correctly assign the label is not encoded in electronic healthcare record, right? There's sort of fundamental uncertainty. You can imagine if you just had like a slice of that image or something, and that's all we could see, like one row of the handwritten digit. It could be a lot of things. That's often the situation in healthcare. There's also this issue of overfitting. So when they first fit Siri, they use a training set and you withhold a test data set. And then when you test it on another data set, it's performing swaps. That's very typical, right? And so the first model is overfit. So that even the first model is not a perfect classifier. The second one definitely not a perfect classifier. But still has a pretty high area under the receiver operating curve. So good model, 0.88. But if you don't have a perfect classifier, you have to pick a threshold for clinical action. And that threshold for clinical action is either going to give you false positives or false negatives. And that's where the ethics comes in a very concrete way. So, sorry, let's close.
And can you press it okay?
Oh, no.
Yes.
All right, there we go. All right. So we don't have a perfect classifier, right? We can't say, 100% probability you're going to die, 0% probability you're going to die. We're going to be somewhere in the middle. So this is what I think we're all familiar with, is the idea of estimating a patient's risk. So the outcome we want to predict is whether they're going to be dead or not. The data we have to make that prediction is this 390 variables electronic healthcare record. And so we construct this risk score R, which is the probability that Y equals 1 conditional upon that patient's characteristics. And in Siri, what they did was they calculated the probability the patient would be dead the next 90 days, conditional based on their values of their features. And so we often, what will happen is these algorithms will spit out not like this patient's definitely going to die, or our guess is death, like doesn't show an epic, like going to die, right? It gives you a risk score, often not actually translated into a concrete number like this. It's like red or something, for some green or something, right? But in this case, Siri actually did make predictions like this. Like this man has a 60% chance of dying in the next 90 days. So the model is more often than not, the model he'll die, but there's still 40% chance he won't. And we're unable to achieve, based on the available information and current AI techniques, that sort of perfect separation, right? That perfect classification pass. Otherwise, if we were, this would be 0 or 100. That makes sense. So there's kind of fundamental uncertainty, irreducible error. And in the context of irreducible error, we had kind of ended up having to use some ethics. So when you have a risk score like that, where that ranges between 0 and 100% of the outcome, you got to pick a cut point to do something about it, right? This is the problem with medicine. A lot of times treatments are very binary. You either treat the patient or you don't. In the context of Siri, it was triggering some pop-up, I think, for initially for a goals of care conversation. They had different thresholds for different actions. But let's say, for the simplicity's sake, let's just assume there's one threshold, and it's for someone to go talk to the patient, try to assess their wishes and values about end of life planning. And if normatively you think false positive and false negatives are equally bad, you would always set that threshold to 50%, right? If the threshold's above 50%, you do a goals of care conversation. If it's below, you don't. And so for our first guy, this seems like it's a pretty good threshold, right? We're going to go talk to him, say, this model said it was a 60% chance of death in the next 90 days. Have you thought about how you'd want to live the end of your life if you really are going to die the next 3 months? Probably a much more elegant way than Dr. Cooper is performing it. I'm a pulmonary critical care doctor, so it's more like you're going to die right now. But so that seems okay, right? But what about this patient? She's 71 or 70. She has early stage lung cancer. Admitted for pneumonia. She's not on oxygen. The model uses her 390 variables and said she only got 10% risk of death the next 90 days. But based on our action threshold of 50%, nobody's going to talk to her. She's not getting to talk to Dr. Huber. Is that okay? I mean, one in 10 of patients like her will die. And so it turns out where to set this threshold for clinical action is a clinical medical ethics question. And it has to come down to what's worse, missing patients who are going to have the event, in this case, missing patients who are going to die, which is a false negative, or over treating or over goals of care conversation, and talking to some patients who will end up living. And I bet a lot of people in this room already have an intuition about which one is worse, right? But that's ultimately a normative choice in a particular context. And the people who are designing these algorithms and picking these thresholds, right? They know this kind of intuitively, just like us. And they start, writing stuff like this, right? If limiting the number of false positives is of paramount interest, then a threshold value of 0.7 or higher might be selected. But, translating that, as I think I do on the next slide, it says, we're only going to do a goals of care conversation if that patient is going to die 70% of the time. That's what that means. And conversely, if we made a number of false negatives, then we might want to set it about 0.3. And so what they're saying is, depending on the normative standards of the people who are going to use this algorithm, or what's demanded based on the clinical medical ethics of the scenario, that's how you set this threshold. And so this is their, they have and a lot of times people put these, they're kind of scared about acknowledging what these thresholds are, right? So they make these like red, green, blue, or green, yellow, red meters and make it really qualitative and soft, because I think they're scared of what the implications of this means, or they don't necessarily have the right tools to understand that what they're really doing is making a clinical medical ethics judgment about what's worse, a false positive or a false negative. And so to map this out very explicitly into the confusion matrix, if your Siri is high above the threshold, you get a goals of care conversation, and the patient dies, that's what we want to have happen, and make sure they get someone to talk to them. If they're above the threshold, they get a goals of care conversation, but then they're alive at 90 days, well, that was an unnecessary goals of care conversation. That again, that's for a patient who will live. If we only cared about doing them on patients who are going to die. And then, so that's what a false positive means. What a false negative means is that you miss the opportunity to talk to a patient about their end of life goals who ends up dying at 90 days. And so, not surprisingly, the University of Pittsburgh set the threshold so there was going to be fewer of these than there were. There were going to be fewer false negatives than there were false positives. And so this is again translating the false positive, false negative literature or language into what a false positive and false negative actually means for a real patient. But in the paper, in the supplement, no one's really quite making this jump and making this explicit as it needs to be. So they ended up setting it at 30%. This is something that the data scientists constructing these algorithms just sort of picked maybe at their cursory conversation, but then the people with the clinical medical ethics and clinical expertise to inform this might not know exactly what's going on here statistically. So I think there's just this little bit of a missing link that's potentially very problematic, especially since these algorithms are getting turned on constantly. I don't know how many of you guys have going on in Miami. Do you have anything? Well, yeah, a bunch, right? And they're often designed to prompt clinical actions, right? But what's the threshold? When do they trigger? When does the epic alert pop up? Right? All of these have essential normative dimensions. And so yeah, I think that's the threshold is probably too high, right? A false negative rate of 27% is where they set their threshold. That's a lot of people you're not talking to who are going to end up dead. And there's this other interesting, important issue with this story with this score is that it required complete data on those 390 people. And if you showed up and you hadn't been seen in PMC clinic before, it just was showing on their Epic no Siri, no information. And if you formally inputted that into the model as a prediction of no death, the performance of this model falls apart. So there's another part of this story, which is that there's sort of this ethical responsibility to ensure that the model will operate in practice the way you've tested and validated. And so one of our friend and colleague, Jason Rush, that's what he is building his career around. But we're going to stay firmly in the empirical, or in the abstract realm for this stuff. So that's the end of the first part, and hopefully that story about Siri was, illustrative of, I think, what was a really important medical ethics issue embedded in sort of the routine practice of using algorithm in healthcare. And, for those of us who are interested in ethicists or in ethics or on ethics services, I think underscores the need for us to embed ourselves into these rooms, into these discussions, and also equip ourselves with enough statistical knowledge to understand what's going on. That's what we have to do to meet them halfway. Questions on that part?
Not a question, but what I think we actually asked Dr. Huber, he would recommend that you have goals of care conversations with all patients,
Right.
including those that are well.
Yeah, I know that's.
I wouldn't actually.
Yeah.
They can't. And so you're faced with a scarce resource, which is my time, and then you have to equitably allocate that using AI algorithms.
No, right, no, I think that's the point. There is a cost to a false positive in this context. And, when with epic alerts and two, there's alert fatigue, right? So.
For hospitalized patients.
For hospitalized patients, yeah. I mean, and so if your algorithm, you can get 100% sensitivity by making your threshold 0, right? And you trigger on everything. But the whole point of these things is that they can discriminate statistically between people who are likely to die and not. But when the discrimination is not perfect, which it's not going to be, even with the most advanced AI, it's not going to be able to tell you with 100% certainty that 2 patients are going to die. Then you're faced with this normative choice about what's worse in the given clinical context, a false positive or a false negative. And that's fundamentally something that I think medical ethics has to be involved in, because it is trade-offs between scarce resources for the hospital, like Dr. Huber's time, and outcomes for the patient. Because you're right, there's very little cost to a patient to getting goals of care conversation that will need it. It might free somebody out. If Mike was like, "Hey, let's have a talk," to me, I was like, "Oh my god!" But there's to a hospitalized patient have a conversation about their preferences and values in a formal setting for a long time. There's probably not much harm to that. It's hard to see how that would be harmful to any patient really who's hospitalized, but there's a cost to that to the hospital health system, and ultimately this balance is about comparing those two competing values, and that needs to be said explicitly. And I think people like us need to be there when administrators make these decisions.
Check there's questions in the chat.
Oh yeah, that would mean I need to restart the meeting. No, but yeah. Feel free to show me this.
I feel like you could just go down the rabbit hole for each clinical decision, right? And you're thinking about the risks of the intervention, the benefits of the intervention, the resources involved, and equitable distribution of that. So the interventionist goals of care. I feel like you could just go down an ethical rabbit hole for each of these scenarios, right? And it's just one scenario. So
no, I mean that's why you have to be part of the team that's making these decisions. And the other thing that's I think super interesting too is that sometimes the shape of these curves have different shape. So sometimes the model is better, has like better sensitivity for a given specificity value. So it can perform better at given thresholds. And so sometimes the designers will be like, oh yeah, this seems like the perfect threshold. But it's actually normatively not. It's better to pick a point on this curve that's like worse compared to the conventional statistical framework, which treats true positive and false positive as equally bad, right? So it's sort of ethicists are key for if you're going to weigh one mistake more than the other, that's the choice. And I totally agree, it's context specific, right? But this is obviously very arbitrarily made. 30%. I mean, it's not grounded in any ethical theory that like this number fell out, right? So there's a lot of work that needs to be done. Okay. I don't know. Perfect. All right. So now we're moving on to the second half of the talk, where we'll talk about non-discrimination criteria. Again, restricting ourselves just to this classification problem. As you can imagine, there's a lot of other prediction problems. We might want to predict a continuous variable, what the values of the blood pressure is going to be or something. Often when we're doing that, we'll then translate that to an action. So it does end up becoming a classification task often, but because treatments in medicine are so often binary. But we're going to talk about the way an algorithm can be biased or non-biased and what exactly that means. And before we do that, this here, I don't know, not making it worse. Okay, good, doing better. We have to define what we're talking about being discriminatory over or biased over. And there's a set of patient attributes that are quote unquote sensitive. The patient's gender, race, and this implicit birth, disability, religion, that are explicitly protected under US law. These are often groups that have been subjected to structural violence and marginalized in society. And so a little disclaimer though, everything we're talking about is sort of just considering one of these axes, right? One attribute like race. But intersectionality also poses really big problems where someone may be members of multiple disadvantaged groups across this A vector, right? And that makes things even more complicated. But what we're going to talk about is just sort of imagining hypothetically that there's sort of an in-group and an out-group. The out-group has historically been marginalized, subject to violence. Now US law is trying to protect them. How do we make sure that algorithms are not disadvantaging these groups that historically have gotten screwed so bad? That's the general idea. And so that's what this A variable is going to be doing. So we've got the X, the patient's feature, the Y, the outcome, and A is their value, this sensitive attribute. And it turns out there are 3 distinct and mutually exclusive, unless you have a very weird data set, ways an algorithm can be non-discriminatory with different criteria. And we're going to kind of walk through each of these. And ultimately, it's a medical ethics task, a normative decision about which criteria is appropriate in different clinical scenarios. And I honestly don't know the answer to that question, even for the problems I think about a lot. The first one's easiest. Independence. This is demographic or decision parity. So this means that goals of care conversations are equally likely to happen in Black patients and white patients, right? So that the probability that your risk score is above the threshold is the same regardless of what your value of A is. So man and woman, same rate of goal of care conversation, right? In this example, white patients were more likely to have an elevated series score, probably because their outpatient medical record was better documented, one would assume. And so this Siri violates this independence criteria of treating people. You can think about this as like treating people equally, sort of strict equality of clinical action, right? Well, what's the problem with that? It turns out that often, if you have enough features or enough information, you can sort of perfectly predict A. So there's this example in the book about browser histories being, you can build a classifier based on browser history and predict someone's gender almost perfectly. So if the feature A and X are really correlated and you build a prediction model, you're going to end up with problems with independence if you're trying to uphold that, right? So you basically have to make your model intentionally less accurate. Because if there are real differences in the risk of dying across levels of A, the model is going to learn that. So you sort of have to handicap your model to make independence. There's this idea of like the 80% rule, which is you can have some inequality of predictions or of clinical action within some margin, right? Perhaps this would be acceptable, right? I mean, well, it's not like 0% of Black patients are hitting the threshold, 7%. So it satisfies independence within some error rate. But then comes the next problem. Well, what if in reality, Black patients were more likely to die than white patients? And that's, you know, epidemiologically true for your patient population. Wouldn't you want to assign more goals of care conversations to that particular subgroup of the sensitive characteristic? So this is an equal, does not equal equitable problem, right? I don't have the picture of the kids with boxes, but you get it, right? You know, everybody's trying to see over the fence. Some people might need more to see over the fence. And independence risks normalizing and reinforcing healthcare inequity. So, like for imagine trying to do this for blood pressure, and you were like, "Oh, we want to make sure everyone is getting the same blood pressure treatment, same rate of blood pressure treatment, regardless of their race." And so you set the definition of the hypertension to be different for Black patients and white patients to achieve independence, right? That obviously is problematic on its face. So there's this risk with independence of reinforcing healthcare inequities, right? So independence alone has a lot of problems. Questions on this one? All right. Now it gets harder. The last two are harder, but we'll go through this slowly and hopefully we can all understand it together. Separation is the idea that error rates are the same across levels of A. So the model is sort of equally as accurate in terms of sensitivity and specificity for white and Black patients in this context, or A equals A or A equals B, male or female, pick your characteristic. So this is like, for example, you pick this is the curve for group B, this is a curve for group A. And separation requires you to pick the threshold of treatment action at the point where the error rates are the same. So the model is equally as sensitive and equally as specific at the threshold that you trigger the goals of care consult for both, for example, to sit with race, white and Black patients. So if you're getting a series triggering, telling Dr. Huber to go see you, that person's true positive rate and false positive rate are going to be the same regardless of their race. So this has a lot of appeal, and this is actually what the FDA demands a lot in terms of ensuring algorithmic fairness. That's what Matt shared that, and that's what they're most interested in, is that you're worried, you sometimes worry about a model having a terrible performance in a particular sector, just totally sensitivity and specificity are terrible because you didn't bother to recruit any of them into your training set, so you can't achieve separation at all. That's what they're mostly worried about, is that the model will perform really poorly, and that the threshold that you set for the in-group, the dominant group, is not going to lead to a very good, it might be a coin flip for the algorithm. So that's nice. So it has some appeal. And this is, if this is confusing, you're not alone. It's something I've done 20 times, so I'll wrap your head around. But it makes sense that you don't want to be using a threshold derived in one population that has your sort of optimal false positive, false negative rate, then in a different population, a normal population, its false positive rate is way higher. Its false negative rate is way higher because it's way down here. Like their curve looks like this. So what are some critiques of separation? Well, there may be just some irreducible errors in certain populations you can't get around, right? And so it's not the modeler's fault that they can't make the curves cross or find a point of where separation holds. And the other really interesting and problematic issue is that without using someone's sensitive value, you can't find the best classification threshold. So look at this example. Ideally, you might want your threshold to be here for A and here for B. But then think about what you're doing clinically there. You're saying, if you're a man, your gender is male, you don't get a series, you don't get a goals of care consult until your threshold is 0.4. But if it's a woman, it's 0.2. So you're treating patients explicitly differently based on the value of the sensitive attribute, which is in general
on its face, inconsistent with all these constitutional provisions. But that's actually the best way to make the error rates as low as possible for those groups. Yeah, I know. There's another one, man. All right, so that's the other. The last idea is that the score sufficiency, so that means the score means the same thing. This is also called calibration error, which is that if the model says you got a 50% chance of dying, you have a 50% chance of dying. It turns out with a sufficiently large data set, it's pretty easy to meet the standard. As long as you have enough features, as long as your model is pretty accurate overall, and there's variation in those features across the levels of the sensitive attribute, you're going to be able to meet this standard. So it's sort of from a technical standpoint, often the easiest ones, which is that and it doesn't require the threshold too. It's true like across all the thresholds, any threshold this one is independent of the threshold. So it's ironic, it's interesting in the sense that it means that like at any point you want to trigger a global care consult or any particular score value, it has to hold, but it's easier in practice to achieve than separations. So in my research, we analyze crisis areas of care algorithms, and this is a life support allocation simulation where we compared lottery to using the sequential organ failure assessment score, or SOFA score, which is the dominant scoring tool in crisis areas of care across the country. And we found that Black patients were assigned higher SOFA scores than white patients who had the same probability of dying. So basically it said, because of the renal component of the score and higher rates of chronic kidney disease amongst patients who are Black and in this situation, they got higher SOFA scores. And then what's confusing about this, I mean, in the simulation, they got assigned less ventilators and they ended up dying more than a random lottery, of course, all simulated, but still an example of where a sufficiency error, because SOFA is not a fancy machine learning model. SOFA is something they made up in the 90s, not a regression model at all. Causes a miscalibration and bias against Black patients in a very particular way, that under allocation of resource because the model is miscalibrated for a particular group. So this is an example of a sufficiency error that could have really problematic consequences. And so I made this point earlier, there's these three different ideas. And it turns out when you kind of do all the math, they're not going to be mutually satisfied. Like you're going to have to pick one or the other for the most of the point. You can sometimes get like separation and sufficiency if you're lucky, but often you're picking your poison here. And I don't really know the answer to which one of these ideas is best in a lot of these common clinical scenarios, even with Siri that we've been talking about this whole time. Separation at the treatment threshold has a lot of appeal too. But sometimes it seems like it might be appropriate to use a little level of the sensitive attribute to achieve some of these things. So in liver transplantation, for example, turned out that the model for end-stage liver disease had a calibration error for women, and they were dying at higher rates than their MELD would predict. So they fixed that, and in order to do that, to fix it, they explicitly use sex, biological sex, one of the characteristics. But that seems justified, right, to meet sufficiency. So this is a developing literature space. There's a fourth idea too of contractual awareness, which is like more about counterfactuals, is even more statistically complicated. But so there's developing literature in the machine learning world, and I think it's important for clinical medical ethics to engage in this issue. And because you're going to be asked, like, this is algorithm fair? And the answer is depends fair according to what standard. And it really, I think, depends on the clinical details of the clinical scenario. So, I mean, I think what you asked, like, what is quantitative bioethics? It's this, right? It's this idea that, non-discrimination criteria play a really important role in the machine learning algorithm development process. You have to kind of go in thinking about which criteria is most appropriate in that particular setting, rather than just fitting the model and trying to fix something back end, which is what they're doing now. And they can also diagnose health inequities in a unique way in the status quo. You can evaluate current algorithms according to these criteria and find kind of shocking results like we did with SOFA. So they're really, I think, really important. And all right, well, with that, I think I'm close to wrapping up. I don't know what time it is. But perfect. So I'll just do my conclusions and then we can talk and do questions. So first thing is that people are hard to classify. There's irreducible error in the system. It's not the digit problem. We're never going to be perfectly classifying human beings when living or dying at a concrete time point. There's always going to be fundamental uncertainty. And in that situation, fundamental uncertainty, the choice of treatment threshold is ultimately the normative one and relies on principles of clinical medical ethics. When you think about making sure that your classification task is fair across levels of a sensitive attribute A, there are multiple mutually exclusive concepts of fairness. And there needs to be philosophy done to argue that one is the correct one in that particular scenario. And it's not, none of this just falls out of the math, I think, right? And finally, I don't know if I agree with this last bullet point anymore, but that's what I wrote. That sufficiency errors when they occur, seem like overtly unfair, as in with the SOFA case, of just saying, literally systematically excluding members of a disadvantaged group from treatment because you're miscalibrated. That seems pretty problematic. But you could imagine that in an allocation of an organ, perhaps ensuring that separation is met at the threshold, the typical threshold for which melt, like at a melt of 35, or melt was lower than that. Median melt is like 28, 29. At that median melt, you have all the error rates are the same across levels of the characteristic. That also seems intuitively fair, but that's not a full-fledged argument at all. So I just want to end by thanking my mentors, of course, my host, Dr. Keeper, and Dr. And the Bioethics Institute for this opportunity. And I'm really looking forward to your questions and comments, and I'm glad we have some time for discussion. Thank you. Normally I'm 2 minute slides, guys. Right at the end, I need to pay myself. So thanks so much.
Thank you. And maybe do look at the chat and see if anyone has some slides.
Not yet.
Yes,
Great presentation.
Thanks.
I'm exposing that I'm still wrapping my head around the allocation fairness options. But the one piece that you mentioned is oftentimes the training data for these algorithms will be systematically missing data from disadvantaged groups. Right. All three of those are going to have a problem with that, right? None of those, like, none of the calibration can.
No, it's possible that you have none of them. So like, it's not like you're gonna get one no matter what, right? I mean, lottery always gives you.
But is it
right? Like ignoring, just randomly allocating the thing, or randomly deciding to treat it out will give you independence, but no, this.
But no one, if you know your training data set is for sure missing data in a biased way.
Yeah.
That does not inform, that doesn't tell you, oh, we should choose, we are better off if we, on the back end, are trying to do work.
Yeah, I mean, I think sometimes it depends, like on this. Sometimes these tools can be helpful for making you think about that when you're collecting the data, right? And recognize that this might be a problem. But yeah, I mean, if the data is just not there, you're not going to meet separation because that the curve for the disadvantaged group is gonna be a coin flip, right? And, because they don't have, the values of X are missing for them in a systematic bias consistent way. They're missing not every, this way, yeah, it's that the key variables for the prediction algorithm are just more likely to be missing in the disadvantaged groups, then your ability to predict their outcome is gonna go down. You're not gonna be either calibration or separation or sufficiency. Yeah, so but yeah, that's, I mean, it's a big problem, but I think the idea is these concepts can help you diagnose that issue earlier. And be aware of it rather than just like you turn it on in Epic. And you see like 2 months later, like, oh god, this is not doing well. Right. So it's definitely upstream.
Thank you so much for your talk. It was wonderful. I was wondering if the clinicians aren't seeing what goes into developing the fairness in the algorithm and they just get a pop-up box on Epic, how do you think that impacts kind of their role in shared decision-making and their discussions about, hey, this box popped up? When if you take separation, there are different thresholds for different patients, and they may not see it as if they were looking at a lit review and said, oh, my patient doesn't fit in this study well, so let me make sure that's clear to them
Right.
during that kind of counseling and their recommendations.
Yeah, it's this idea.
Can
that
you make sure
you
that
don't
people on Zoom actually heard that?
Do you guys hear that?
I like the space.
Oh, yeah.
What is ring loss? To summarize it briefly.
Yeah, I will make sure it's summarized. So that the idea is, when they're, if I understood you correctly, the thresholds are being set up, by the algorithm designers. That's what prompts the box from popping up. The clinicians at the bedside may not know about these fairness concepts at all, right? Or that it may be more or less accurate in a particular population. But the also thing I think I heard in there was like, you could just sort of say, show the clinician the risk score, like the actual value, and not actually prompt any specific clinical action. Or you put some text, this may mean this, right? And allow them to use their clinical judgment in addition to the value that they're getting from the algorithm, without sort of like, I mean, and often that's what these things are, but
Yeah.
so you are picking a threshold to like send the epic nudge to you. So I don't think you can totally get away from the fact that thresholds are going to be relevant, but yeah, and then having disclaimers about potential limitations, but if you don't look for these things during the algorithmic testing or training and testing part, you're not going to know they're there, right? So it makes it even harder for the investigators. Was that what you were asking, or?
Yeah, I guess I was just thinking that we're worried about the fairness from the development standpoint, that the clinicians don't even know that their patient wasn't even like the one that they're using the best threshold for, unless they're doing separation. Like if they don't have that information, it might impact their counseling and make it more unfair.
Right, all they see is the
Yeah.
threshold value,
The
the probability.
yeah.
All they get is the probability, maybe the probability, sometimes just get a color. And they get the probability and then a recommended action, right? But they don't, it's not, there isn't a disclaimer that has this curve or right, the separation curve, right? Like, oh, this is this model's entire characteristic. And the number of physicians who can successfully interpret one of these things is probably small too. I mean, it's confusing enough for somebody who has a PhD in research to me. So I mean, it's not, I don't think that's something that we can, I think it does have to be done at the algorithm side. And there's all this implementation science world about how to make sure that when you turn these things on, people respond to them in the right way. But if you don't, like, you still have to do the upstream stuff, I think, and that work is so, it's all.
I think
On that, so sorry, last question.
so there's attention to developing sort of physician literacy level, like scorecards or warning labels that go when these algorithms were implemented to try to make it digestible. Obviously, you need to do the upstream work. I think there's a lot of interest in the implementation side of like sort of like an FTA label that shows how the algorithm was made, where the training data came from, and should include these kinds of normative decisions, and that, we are using algorithms if we don't have them.
The other thing the last thing I'll say about it, it's like you may design an algorithm to do one thing, like trigger goals and care consults, but people may use it for a different one. One example that came up was a prediction for mortality was being used for transplant candidacy. Like, oh, it's too high, they're not gonna list them, but it's too high because they're gonna die without a transplant, right? Like, that's not predicting their probability of survival with a liver transplant, it's the probability of survival without a transplant. So but people can use these scores in ways that were intended to, right? For different clinical decisions, which of course would have a totally different balance of false positives and false negatives, different threshold versus the one you design a trigger threshold based on one clinical problem. Even if you do that really thoughtfully, with the ethicists embedded, then people are using it to do a totally different decision. You have no idea what this curve looks like.
On that note, what you've made clear, among other things, your brilliant presentation is that while in predictive analytics, you might need disclaimers. In ethics, we don't always need them. Thank you so much, Dr. Parker, Dr. Huber, thank you.
Curious to hear your thoughts. Hear my thoughts. Yeah, I feel like at some point you